Hello, everyone, and good evening. My name is Ariella Shoham, and I lead Aidoc's marketing. And I think that every year at RSNA, we forget that it's actually Thanksgiving, and Thanksgiving is a time to say thank you. And I want to say thank you from all us at Aidoc to all of you for being our partners and for working with us and for believing in AI. And we are so excited to have you all here with us. And so thank you very, very much. I'm excited to be kicking off this evening with two amazing speakers. We have Nina Kottler, I'm going to read out this title, who is the Associate Chief Medical Officer AI at Radiology Partners and also the Associate Fellow at Stanford AV Center. And with her, we have Jim Hinton, who has held the leadership positions of CEO at the Presbyterian New Mexico and Baylor Scott & White in Texas, and is currently an advisor and board member of various companies. Before I hand it over to Nina to kick this off, I'm just going to let Elad, our CEO, say a few welcome words, and we're going to kick this off. Thank you.
Thank you. And promise it's going to be really short. So, first of all, thank you everybody for coming. I know how hectic RSNA dinners can be, and I know each and every person in this room has, 4 dinner invites. But I think what we're going to do today is fairly special. And I think the angle we wanted to talk about today isn't really about AI per se. I think it's way more about the role of radiology as it evolves from the perspective of the health system. I think there is a unique opportunity with AI over the next few years, together with radiology, to play a broader and broader role within general I would say, the envisioning of the health system of the future. So thank you for senior speakers, and I'll let you take it from there.
Thank you. So is that too loud?
No.
All right, good. So thank you guys. Thanks for everyone for being here. And Jim, thank you for coming. We are going to be talking a bit up here back and forth, but it is also going to be a bit of an interactive discussion. And just so while everyone's a little bit still getting settled, I thought I'd walk around the room a little bit because I am going to ask the audience a few questions, right? So get ready to raise your hands. They're simple, just raise hands questions. First question is, anyone, whether you are a healthcare provider, more? Okay, all right, there we go. Whether you are a healthcare provider or a radiology practice, who here is having problems with the amount of imaging volume outpacing your capacity to read? Anyone? All right. Now there's a laugh, right? Like, it is insane. All right. Who then is having trouble with increasing turnaround times? Right? Patient care is getting delayed, turnaround time, we just don't have enough people to do all the work. Who is having trouble hiring, whether it is radiologists, nurses, techs, right? This is an unprecedented time in radiology. And I tell you, I've been in radiology for 17 years, and I've never felt anything quite like I feel today. And in the past, there's always been times where we don't have enough radiologists, you don't have enough people to go around, and the volume is outmatching your capacity, but it's cyclic, like it comes back and then it comes back up. And it's usually what, every 4 years? This does not feel cyclic to me. This time feels very different. And in fact, we're seeing that difference now. More job postings in the ACR than we've ever seen. The cost of hiring a radiologist keeps going up and up while our reimbursements at the same time are going down and down. It's an unsustainable state. And it makes you wonder, where is this going to end? What is going to happen? I will tell you, in the past, in my practice, we used to answer RFPs for healthcare centers that were looking for our work. And we would be competing against multiple other groups. Now, they're coming to us and there's no one else competing. They're going to different groups and saying, please help me. You know why? Because their radiology practice fired the hospital. They had to let go of their contracts. Some of them just can't afford to cover them anymore. And others are actually imploding. The radiology group is no longer even there. It is insane. And I think we need to be able to do something different than we're doing today. But I do think that any challenging time is also an opportunity. So I want to hear, Jim, from you. What is the perspective of the health system?
Well, I thought I might follow your lead and ask that anybody who regrets that they haven't thanked their hospital CEO enough, please raise your hand. It's not too late. You can go back if you're affiliated with a health system or a hospital. You can go back and thank them for all the things they're doing. But in all seriousness, glad to be here, Nina. Thank you, and thanks, Elad, for the invitation. This is a tough time for hospitals, and it's there's the old story about if you have one hand in the refrigerator and one hand in the oven, on average, your body temperature is about right. Well, 2 years ago, hospitals got a whole bunch of cash from the federal government for COVID, and they had the best years they've ever had. They then took that cash and they put it on their balance sheets, or they expanded into building hospitals or clinics or making other investments. But the money that they left on their balance sheet is subject to this 25 to 30% decline in investment values. And so most hospitals are at break even at best. Now, there's some exceptions to that, but it's a really tough time. You add to that the cost of hiring that Nina mentioned, and it's a really, really challenging time. There will be probably 600 or so hospitals this year that go out of business. They will tend to be smaller. They will tend to be in rural communities. But in urban communities, there are some that are going to go out of business as well. So I guess, Nina, my brother's a radiologist. I just have to say that as I get started. I feel compelled to say that. He gave me a whole list of things that he wanted me to say that, of course, I tore up just because of the general tension between administrators and doctors and siblings. And so the combination of those two I haven't said. But again, in all seriousness, what's happening in healthcare right now is impacting everybody, and it's real and it's serious. And I think collectively we have to do everything we can to make the practice of medicine more effective, more efficient, and more humane for those people that practice.
Yeah, it's unprecedented times. And when you're seeing radiology practices close their doors and hospitals close their doors, all the things that we're trying to do, making healthcare more equitable, making it available to all kinds of patient populations, improving the quality of care. Like, how can you do that in this kind of situation? It's very difficult. I will say at the same time, we've always had a call to action in healthcare. Even without this backdrop, we have needed to improve the value of what we're doing. We spend the most amount of money on healthcare in any nation in the world, and yet our outcomes are very poor. So how is it that we can both improve the value that we provide and do it in this backdrop where there is basically a difficult time hiring the people that you need to manage that? Frankly, the only way I've ever seen that work is by using technology. Right? Technology is the great equalizer. It allows us to both improve our quality, but at the same time, decrease our cost. So asking you, Jim, then, how have you seen technology, or how do you see technology within healthcare?
Well, when I think about it in three layers, I think there's this transactional layer that includes EMRs that you all know and love, either in your practices outside the hospital or in the hospital. There's the intelligence layer that a lot of people are working on building, which is where artificial intelligence, machine learning comes in. And then there's the consumer layer of how can health systems better connect with the people that they serve. Now, the transaction layer was the worst of both worlds. It was very expensive to put in, And then most hospitals and probably physician practices had to hire scribes and other human beings to make that system work. And so we don't want to replicate that one. What we need to do is we need to make technology investments that allow us to hire fewer human beings, automate mundane work that can be automated. And then in that consumer layer, we're competing with Amazon, we're competing with any of your favorite apps for convenience, for information, and there's another big battle that's happening there.
It's always strange to me that we use humans to replace things that computers do so well. It doesn't make any sense. So yeah, the EMR, the transactional, I like that term, transactional layer, because it is not an intelligent layer. It is not a patient-driven layer. It's really a layer that's just managing billing so you can get paid. What layer do you think we're in out of those three right now?
Well, yeah, I think the game's over on the transaction layer. I think it's primarily Epic. It's in hospitals, and Cerner and Meditech and others play some role in that. Those systems are still being optimized. Those systems still require a lot of human support to succeed. I think the battle is in this intelligence layer. I think the secret is out that there are a lot of diagnostic errors. The secret is out that, patients could be getting better, safer, more efficient care if there was more technology applied to the care that they need. And that from consumers, consumers are just generally pissed off about everything. And I think they want things to work better in hospitals. And I retired from Baylor Scott and White last December, and I'm not completely just a random patient now, but it is hard to get into health systems. It is hard to get in and get services.
Yeah.
People are looking for that.
Yeah. Out of the people here, anyone here, you're all in the transactional layer. That's where you guys all exist right now. You've got EMRs, great. They're not doing that much except for helping you get billing and making our lives a lot harder. Who is in the intelligence layer? Who's deploying any AI right now? Raise your hand if you are. Good. Anyone in the consumer layer, the next one, where you're connecting to your patients? Is anyone there? Yeah?
Not really. We are part of Open Notes, so we make sure that patients can see everything that's happened. We release results almost immediately. We embargo certain things that could be devastating. And we have made our portal such that you can view all of your radiological images. So, patients have found that very engaging. So we didn't even advertise it. We brought it out during the portal during the pandemic, and patients just found it and adopted it. So just trying to make it easier for patients to know what's going on.
Thank you. So important, and not a lot of people are doing it right now, but I think those layers build upon each other. If you want to at least get to the intellectual one, and then go intelligence layer, and then go from there actually to the consumer layer. I want to talk a little bit about what we can think about for the future. I actually have a very strong view about where we're going in radiology in the future. I feel like there's a lot more information that's available. We're getting overwhelmed with information as we start to structure our data. We get information from artificial intelligence, genomics, radiomics, molecular imaging. All of that, I see that coming together at some point, and someone has to contextualize it. And I think the radiologist is really well positioned to do that. I also, of course, I'm biased because I am a radiologist. But I do feel like that we need to remove ourselves from being driven by billing to being driven by patient care solutions, having technology that we're using that is actually going to drive improvements in patient care. So, Jim, in your opinion, what do you think of for the radiology of the future?
Well, so when I started in healthcare right after the earth cooled, the radiologists were part of the clinical team, and physicians, clinicians, internists, surgeons were down in the radiology department talking to the radiologists about what was going on with the patient. And what's happened is radiologists have gotten pushed into dark rooms with screens, and nobody's communicating with them. And I think that has created actually a degradation in the quality of care. And I'm not saying that my brother didn't tell me to say that. I actually arrived at that independently because I've seen that interaction between radiology and clinicians who are taking care of patients directly. And so maybe the opportunity in the future is to bring radiology out of the basement, out of the dark rooms, and get them up there with the technology driving patient outcomes. And I think that is the hope. The other thing is, this is a bad time for everybody, but we're going to get through it. We're going to get through it, right? And people need health care. They want health care. The American healthcare system, with all its flaws, is a good system that can get a lot better. And we will be the ones that deploy the technology that makes it better.
Yeah. You know, what you talked about, going into the reading room with all of the physicians that would come through the reading room, that is exactly why I went into radiology. Because I was evidently in medical school when, in the dark ages with you. And that's how we practiced, because there was no PACS, there was no VR system. So everyone had to, it was like the Starbucks of the hospital. You went to the reading room before you did anything, like you getting your morning coffee. It was wonderful. And it was really better patient care. It's actually sad to me that technology has separated clinicians as opposed to bringing them together. So one more question. What about the future of the health system? How do you think that might evolve?
Well, I think that, ultimately in every business, the consumer wins. The consumer of healthcare is going to win the battle, because they ultimately are the ones paying for it. Now, you might say it's the insurance companies. That's a discussion we can have over another glass of wine. But I think that I think the health system of the future will be dramatically more consumer-centric than the one we have today. And, with all due respect to the radiology portal, when I go into Amazon, I don't want a separate portal to buy boxer shorts, or a separate portal to buy, Metamucil. And I buy both of those actually. I want to go in. I want to have a consumer experience that's built around me. And I think that is going to change healthcare. I really do.
So if we have very few dollars left, like no hospital system has a lot of money lying around, radiology practices, we can barely hire people to keep up with the volume, our reimbursements are going down, there's no money. How do we evolve ourselves to that view of the future?
Well, I don't agree that there's no money. We spend 20% of gross domestic product on healthcare, and there's so much waste in that system that I think the role of the leader, whether they're a clinical leader or an administrative leader like myself, is to find that waste that is not adding value to the patient, get it out of the system, and redeploy those dollars into doing things that help patients. And so nobody cares about healthcare whining about not having any money. I would say if you're using that argument, just stop using it. Because the regulators, the payers in Washington, United Healthcare, God love them, Blue Cross Blue Shield, they don't buy it. And the employers don't buy it for sure. So we just got to stop it. And let's go after the waste. Let's improve the quality. Let's demonstrate the improvement of quality. Let's earn the money we're already being given. And I think this thing can gain a new momentum.
So look for the dollars that are already available, because we're wasting them right now. I think that's important. I think we need to think about how do you have a business case to create the incentive for your hospital or for your radiology practice to decide to move from one layer to the next? Because it does cost money. And while they may say, okay, go find the money that we have to spare or that we're wasting, and then I'll give it to you. They could also say, well, if I could make more money, then maybe that would be a way to be able to afford to pay for this. Raise of hands, is anyone in the room, has anyone been able to convince their hospital system to pay for the cost of the artificial intelligence system? A few people. And the business case that you used to do that, was the business case that you're gonna make your RADs more efficient? That doesn't work so well, right? That's not a great business case. The hospital doesn't care if your RADs are more efficient. The business case, what's that? They want us to be correct.
They want us to make the diagnosis. They want us to be. They don't want us to mess up. But in terms of efficiency, that's our problem in private practice. So, yeah.
Yeah, and they want us to make the diagnosis. And as Jim said, like the cat's out of the hat, that we don't always make the diagnosis. Now, we're our standard of care, but we can be better this standard of care with AI, so we can make more diagnoses. I think there's also a business case to that, right? If you make more diagnoses, then you have more patients coming back into the hospital. Would a hospital care about that if you're retaining more of your patients?
Absolutely, absolutely. And I think patients will seek safer hospitals and clinics. You know, remember, you know, Volvos, I don't know if any of you drive a Volvo, but for many years, their brand promise was around safety. And a lot of people bought Volvos because of the safety of the car or the alleged safety of the car. And I think that why not try to do that same thing in healthcare, where you want to be a place that people want to go because it's safer. And, you know, you talk to enough people at Walmart, I know none of you go to Walmart, but if you did, you would find that everybody has a story about something that went wrong in a hospital stay. Everybody's got a story. So be part of that solution, be part of that movement. I think the impact will be significant.
Yeah, if you can do any of these things and at the time do the right thing for the patient, then you've got the double whammy. I think the last point about this that I've really seen that has made a difference with healthcare facilities purchasing AI or being able to afford it or agreeing to buy it anyway is saving costs, right? You can either increase the revenue or you can decrease the cost. And what's interesting to me, the ways that we can decrease costs by improving the length of stay, decreasing length of stay, or improving the throughput through the ED, these are all fantastic for patients. So you get that double whammy because you're improving patient care.
That's right.
All right, we're getting close to our time. I know you guys are hungry. I just asked if the audience has any questions that they want to raise to talk about with the group.
Can we discuss value-based purchasing, about how it impacts healthcare?
Talk about how.
Value-based purchasing and its impacts on healthcare currently and coming up.
Yeah, so when you say value-based purchasing or value-based care, that means a lot of different things, right? When a patient who's on Medicare gets admitted to a hospital, there is a relatively fixed payment for that admission. So we've had value-based care since we've had DRGs, which goes back a few years, right? And there's all sorts of varieties out there, but the core of value-based care is to create the financial incentive to do the right thing that benefits the patient and lowers cost. And so I think that value-based care is actually the ticket into more automation and more of a brand promise around quality and service that I think some of these investments in technology will actually produce. But it's here to stay. There are very few states where there's pure capitation. Very few states. Medicaid programs in some states. But forms of upside and downside risk are prevalent throughout the United States. And so I think there's an opportunity there to sell what you do based upon those systems. I don't know if did you want to take that another direction or other question? Okay, all right.
Hi, those of us who work in small to medium-sized hospitals, the case to be made to the administration is not that it will save cost, because we have looked at that and there is no convincing case there. But the very convincing case is we are competing with big names in our surrounding areas. We cannot compete with them in terms of treatment, because treatment requires very intense capital expenditure. But we can compete with them in terms of diagnosis. So when a patient comes to my ED, I can confidently discharge him because the Aidoc algorithm and my own analysis showed that it was negative. So that contributes a lot to convincing the administration.
It's a wonderful example. And actually, I do use the Aidoc models. And my favorite model, which I never would have expected, is the fracture detection model. And I didn't think of it because I'm like, you know what? Rib fracture detection. No one does it. They don't treat them. But it ends up that you can tell the patient why they're hurting. And that has a huge amount of value. So if you can improve your diagnosis, I do think it helps both the hospital, but it also really helps the patient. And ultimately, that's why we're in healthcare. Is there one more? I think we're pretty much at time unless, one more. Okay, one more question and then we'll close
I'll
it.
take advantage of having a prior C-suite person here and say not all CEOs have positive views of radiology or radiologists. I said, what is the one or several things that radiologists can do to improve their standing with the C-suite?
How do we get a seat at the table?
Well, you could have your little brother be the CEO of Baylor, Scott and White, I guess. But you know, that takes a little engineering to make that happen. You know, I think it's a new day. I really do believe it's a new day. The boards that I serve on, the companies that I'm advising are asking different questions today, and they are not burdened by some of the patterns of the past where, you know, this doctor's whining, that doctor always whines, or this administrator always says no, or he won't listen, or he delegates it to somebody else. You know, the game has changed and it's gotten a lot more challenging. And I would just encourage you, if you've, you know, to take another run at it but bring to the table data and a focus on value and a focus on what's best for the patients. And, you know, I know a lot of CEOs. I was the chairman of the board of the American Hospital Association a few years ago, and I know a lot of these men and women who have these titles of health system or hospital CEOs. And I can tell you that, you know, there's bad apples in all professions, but the majority of them want to do the right thing. They want to do the right thing. And so appeal to their desire to do the right thing, and I think you might be surprised by the outcome. So that would be my advice.
Yeah, I love what you say about bring data. Data, number one, is not emotional. But in the past, I don't think we've done a good job of that. In radiology, we've always said, I'm the best quality, right? When there's no way to measure who's the best quality, then everyone's an A student. And everyone's raising their hand saying, I'm the best, no, I'm the best. And that doesn't work. You have to bring the data. We have data. So use that to your advantage and solve problems.
Yeah, I agree. Some data is emotional. It's BMI. And so I'd rather, let's not talk about that one, but I don't agree with you on that. So you can.
All right, well, with that topic, let's increase our BMI, have a wonderful dinner, and enjoy your evening. Thank you very much.